So we should observe diaphragm activity, but diaphragm activity can be assessed by esophageal electrodes. If we keep an esophageal probe with electrodes, we can assess the diaphragm activity having transpulmonary pressure also. In advanced ventilator settings, in severe cases of ARDS, we can put an esophageal electrode, we can assess diaphragm activity, neurally mediated diaphragm activity and transpulmonary pressure. The double piston model will increase the pressure from the ventilator and negative pressure from diaphragm. The main idea of this video is we should mainly focus on diaphragm activity, inspiratory effort of the patient when patient is on ventilator. So we should look for in awake spontaneous diaphragm activity will be normal, there will be contraction during inspiration, but in anesthetized paralyzed patient there can be a paradoxical breathing. During inspiration some relaxation of diaphragm and during expiration contraction we can observe paradoxical breathing in some cases. We should look for that paradoxical breathing. So the diaphragm activity, when you keep esophageal electrode, we can assess diaphragm activity and transpulmonary pressure. So diaphragm activity will be positive, and there is diaphragm contraction in the tracings, it will be positive, but during inspiration transpulmonary pressure will be negative, pleural pressure will be negative. So we will get a negative tracing in esophageal electrode. This indicates negative transpulmonary pressure, negative pleural pressure. Okay. Whenever you observe tracings, look at this P esophagus tracing, this indicates transpulmonary pressure. During inspiration there will be negative. So diaphragm activity will be positive in the tracings and esophageal transpulmonary pressure will be negative during inspiration effort. So this is machine triggered because it starts with positive, but this is patient's breath. So this is mandatory machine triggered breath, this is assist control. There is initial negative part. So we should look for key phases of asynchrony, whether the trigger sensitivity is proper or not, about the initial flow phase, rise time, whether rise time is fast, normal or slow, and this pressure control is okay or not, and cycling. Mainly three components are important: what triggers, what controls and what cycles. What triggers? Patient is triggering the breath or machine is triggering the breath? Patient or machine? So what triggers the breath? We should identify that. What controls? Is pressure control mode or volume control mode? In the pressure tracing, it is square means pressure control mode. So what control? Then what cycles? Cycling means change from inspiration to expiration. What is changing inspiration phase to expiration phase? Whether it is time triggered or flow triggered. So what triggers, what controls and what cycles. So what triggers means patient triggered or machine triggered. What controls means is under pressure control or volume control. What cycles, what is changing the inspiratory phase to expiratory phase. Time, fixed time, set time or set flow. So normally at the end of expiration, alveolar pressure will be 0. At the end of expiration, alveolar pressure will be 0. Pleural pressure will be 0. But during inspiration, chest expansion, diaphragm contraction, with negative intrapleural pressure, -5. This causes inspiratory flow and alveolar pressure will be, there will be inspiratory flow because of negative intrapleural pressure and negative alveolar pressure, there will be inspiratory flow. So normally physiologically at end expiration alveolar pressure will be 0. Okay. In understanding respiratory mechanics, we should know the amount of airway resistance and the compliance, amount of compliance. So in the congestive cardiac failure, if there is interstitial edema, if there is alveolar involvement, A classical case of congestive cardiac failure, in early stages there will be interstitial edema. So, there will be alveolar edema. Initial interstitial edema followed by alveolar edema, then there will be bronchial edema, bronchoconstriction. So, if there is pure interstitial edema, what happens to the alveoli? There will be collapse of the alveoli, fluid accumulation, there will be oxygenation defect, PaO2 will be reduced. But what about PCO2? In interstitial edema, there is alveolar involvement, whether due to edema or any alveolar fibrosis or pneumonia affecting alveoli or any pneumoconiosis affecting alveoli. If there is pure alveolar involvement, only oxygen is affected, there will be hypoxia, but there will not be hypercarbia, PCO2 will be normal. When diffusion membrane is affected, both oxygen and CO2, there will be change in oxygen and CO2. Oxygen should be low and CO2 should be high if there is diffusion membrane disease. But in all cases, PO2 will be low and PCO2 will be normal. That is the reason why we call it as oxygenation failure. The reason is diffusion capacity of carbon dioxide is 24 times more than oxygen. Diffusion capacity of CO2 is very high, it is 25 times higher than oxygen. So, whenever there is interstitial disease or alveolar disease, oxygen will be low, but CO2 will be normal. The reason is diffusion capacity of CO2 is very high, 25 times higher than oxygen. So, when CO2 will be high, if there is airway obstruction, if there is ventilation failure, if there is hypoventilation, then only CO2 will be high. So, in case of interstitial causes and alveolar causes, only there will be hypoxia, PO2 will be low, PCO2 will be normal. Clinically, in ABG, if PCO2 is normal and PO2 is low, that is oxygenation failure. In conscious patient, if there is oxygenation failure, we will give NIV. We will try with NIV, non-invasive ventilation, with CPAP. What is CPAP? We will provide a positive end expiratory pressure. We will provide positive end expiratory pressure, that is PEEP. What is JEEP? JEEP is zero end expiratory pressure. Now, physiologically, end expiratory pressure will be 0, that is JEEP. If there is alveolar edema, to prevent alveolar collapse, we will maintain positive end expiratory pressure, that is PEEP. In NIV, that is called as CPAP, continuous positive airway pressure, means there is continuous positive end expiratory pressure that prevents alveolar collapse. That continuous positive end expiratory pressure prevents alveolar collapse, that clears edema, and there will be recruitment of alveoli. If there is proper recruitment of alveoli, that improves ventilation perfusion ratio, even intrapulmonary shunting. So, in oxygenation failure, we will start with NIV, CPAP, or in ventilatory mode, we will focus mainly on PEEP, to provide PEEP. How PEEP will be provided? By increasing FiO2 or by increasing mean airway pressure. We will set PEEP. How to improve oxygenation? Again, we increase mean airway pressure, we will increase FiO2. So, in pure oxygenation failure, we will focus on PEEP and then FiO2, mean airway pressure. So, if there is airway involvement, bronchial involvement, in classical bronchial asthma, in pure airway involvement, we expect high CO2, because this is ventilation failure. In ventilation failure, there will be high CO2. If there is significant ventilation failure, if there is both airway and alveolar involvement, there will be hypoxia and hypercarbia, both low PO2 and high CO2. So, if you find ventilation failure, if there is high CO2, we should start with BiPAP. In NIV, we should start with BiPAP. If you observe ventilator failure, or combined ventilator and oxygen failure, we should start with BiPAP. What is BiPAP? In CPAP, we aim at end expiration. We will maintain positive end expiratory pressure. We adjust the PEEP valve, so end expiratory pressure will be positive. Okay. In BiPAP, we will adjust both inspiratory pressure, Bi means inspiratory pressure and expiratory pressure, that is IPAP and EPAP. Inspiratory positive airway pressure, that is IPAP, and expiratory positive airway pressure, that is EPAP. The difference between IPAP and EPAP is pressure support. If you maintain end expiratory positive pressure EPAP, if you set EPAP at 5, if you set IPAP at 10, so during inspiration there will be 10 positive pressure, expiration there will be 5 positive pressure. The difference is pressure support. What is the difference? 5. That 5 is pressure support. That is pressure support with CPAP. So we should look at patient lungs. We should check the amount of airway resistance and compliance. We should mainly focus on airway resistance and compliance part. We should peep into lungs before setting PEEP. We should peep into alveoli, airways and alveoli. So if there is interstitial edema, we should maintain positive pressure in the alveoli. Alveolar pressure should be positive. So if there is alveolar edema, any alveolar damage without CPAP, during inspiration there is airflow, but during expiration, if there is alveolar or terminal airways damage because of valve mechanism, terminal airways may get collapsed. There will be collapse of terminal airways and there may not be expiratory airflow. But if you maintain CPAP, expiratory flow will be maintained. Alveoli are opened. So normal alveoli, collapsed alveoli. If you maintain CPAP, continuous positive airway pressure, the alveoli will be opened. There will be recruitment of alveoli and there will be clearance of fluid and ventilation perfusion ratio will be normal and intrapulmonary shunting will be reduced. That is the advantage with CPAP. So without CPAP, lack of gas exchange, because ventilation VQ is affected, VQ mismatch. But with CPAP, it corrects VQ mismatch. It provides alveolar oxygenation. So in oxygenation failure, in pure oxygenation failure, we will plan for CPAP. If there is ventilation failure, go for BiPAP. Or if there is combined ventilation oxygenation failure, go for BiPAP in NIV. Control modes. In control modes, routinely we use volume control mode. But if there is severe ARDS with significant alveolar damage, we have to go for pressure control mode. So if there is severe alveolar damage, predominant alveolar damage, we should look for pressure support mode, at least pressure control or pressure support mode. So alveoli, some alveoli in ARDS there are various zones. In some zones alveoli are normal or some zones they are diseased, but with CPAP, aeration and there will be expansion of alveoli, contracted alveoli, but with still good aeration, and some alveoli are collapsed. So advantage is recruitment of alveoli, but disadvantage is if you give excess pressure, normal alveoli, there will be over distension. So CPAP means continuous positive pressure. Okay. So there are various mechanisms of gas exchange, the convection, diffusion, and this pendulum. There are various mechanisms. We should know all the mechanisms of alveolar gas exchange. So we should know about time constants. In ventilator settings, we can know time constants. In fast units, short time constants. In slow units, long time constants. So in the alveolar, in alveolar oxygenation, there is pendulum. It will move from the fast units to slow units. Again, there are channels of Martin, canals of Lambert, there will be pores of Kohn. In between collapsed alveoli and normal alveoli, contracted alveoli and distant alveoli, there will be exchange in between those alveoli. through these channels of Martin, canals of Lambert, pores of Kohn, and through Pendeloft mechanism, the Taylor dispersion, the molecular diffusion mechanisms. There are various mechanisms. So, if you maintain PEEP, there are various mechanisms among the alveoli, in the various zones of alveoli, through molecular diffusion or through various pores, the molecular diffusion mechanism. So, which mode you prefer? Volume mode, volume control mode, or pressure control mode? Okay. Routinely we prefer, we will start with volume control mode. With inspiratory hold, depending on the peak pressure and plateau pressure, and depending on the compliance, how compliance is affected or resistance is affected, you can change it to pressure mode. That we will discuss later. So, we should know stress and strain, intensity property from ventilator side and capacitance property from the patient side. If compliance is low, there will be more strain to the lungs. We can know stress index whether it is less than 1 or more than 1 in the scalars and loops. Here inspiration time is 4 seconds, expiration is 0.6 seconds. The patient has pneumothorax. So, with low lung volume, with low tidal volume, there is a risk of atelectatic trauma, lung inhomogeneity. High tidal volumes, there is chance for valve distension and air leaks. So, there is various zones. In some zones alveoli are normal and distended, in some zones alveoli are collapsed, in few zones alveoli are completely collapsed and contracted. All alveoli are not equal, depending on involvement of alveoli in various zones, we should change the settings. So, normal alveoli, but in ARDS, if you increase tidal volume, some alveoli they are valve distended, some are collapsed. So, in ARDS emerging concepts are, we should prefer low tidal volumes and low plateau pressure, less than 30, so 6 ml per kg, and high PEEP, open lung approach, low driving pressure, low ventilating power. So, initially respiratory rate, tidal volume and plateau pressures are important, but nowadays mainly we are focusing on driving pressure and mechanical power. So, in ARDS, in positive pressure ventilation, lung protective ventilation and open lung ventilation methods. So, in mild ARDS, NIV with low moderate PEEP, low tidal ventilation. In moderate ARDS, high PEEP and changing various settings with pressure control, pressure support modes. In severe ARDS, the last option is HFOV method, when this is carbon dioxide removal, like ECMO, there is a carbon dioxide removal method, ECCO2R, and prone positioning, prone ventilation, neuromuscular blockades, inhaled NO. Last option is ECMO. Okay. The compliance. Compliance is decreased, there will be rightward shift of curve. So, in severe ARDS, there is complete rightward shift of curve. Actually, we expect a curve like this, but in severe ARDS, almost flat, complete rightward shift of the curve. After surfactant, 6 hours after surfactant, lungs are improved and curve is a normal curve. So, ventilation is needed to sustain life, but we should prevent ventilation induced lung injury. So, we should be more cautious. First, we should do no harm. Patient or machine, they are ready to tell stories, but we should be a good listener. Here, either tell me the story. Whenever you go there, ventilator asks you, I am ready to tell some stories. Are you ready to listen? What story ventilator is ready to tell? Here, set tidal volume is 450, but tidal volume, what patient is getting is 760. Set tidal volume is 450 only, but what patient is getting is 760. How it is possible? That time patient is getting nebulization, but nebulization, that additional volume is recording the additional volume. set tidal volume, patient is getting nebulization. So, that additional volume patient is getting at that point of time. Intensivist, the role of intensivist is every breath you take, every move you make, every breath you take, every move you make, every breath you take, every move you make, I will monitor you. Okay, thank you.